All right. Hey, everybody. My name is Missy Scalise. I'm a general internist, and I wanted to basically meld my two loves. Well, my two loves after my first two kids. So my third and fourth loves, fitness and then medical education. So I'd like to do a 20-minute workout where I talk about the latest sort of medical topics that have come about. I'm a primary care physician, general internist, and so I'm going to be mostly picking topics related to what I do, but they probably also relate to a number of different other specialties. So the way the workout is going to work is it's going to be every 2 minutes. We are going to switch from a base to a push. So your base is going to be your lower level of intensity. And you're going to do that for 2 minutes, and then we're going to do 2 minutes of a push, which is the higher level of intensity. Now I'm going to be walking at my base and then walking a little bit faster at my push, but you can choose to do whatever you'd like. So you can jog, you can run, you can walk, you can power walk, just kind of whatever works best for you, go ahead and do it. But I'll be prompting you every 2 minutes to either do a base or a push. So that's kind of how this is going to work. And then interspersed into that, I'm going to talk about a bunch of different medical topics, so probably 5 or 6 different topics. Should be a lot of fun. I'm super excited. Thank you for bearing with me, as this is my first time doing this. And I think I have a lot of learning to do, but don't we all, right? So I'm going to go ahead and get started. My base is going to be anywhere from a 2 to a 3, so I'll just have you meet me there, kind of get into the flow of things. And then in about 2 minutes or so, I'm going to have you do a push with me for another 2 minutes. So that's kind of how it's going to work. All right, so let's go ahead and just jump right into our first medical topic. So the first topic I'm going to talk about is something new and improved. It is the Prevent calculator. So before, for cardiovascular risk prognostication, we used to use the ASCVD risk calculator. And so we would calculate the patient's risk based on a number of different factors: their age, their sex, their race, their cholesterol, their blood pressure. And then we put it into a calculator and determine what the risk of cardiovascular disease is over the next 10 years or lifetime, just depending. And, I use that all the time. It would help me in my decision-making with patients. But I always felt like there was maybe a little overestimation of the risk whenever I used it, but it was the best that we had. So now they have come up with a new calculator called the Prevent calculator. And the difference in how these risks were calculated was that it was taken from a lot more people than the prior calculator. So the data was taken from 3.3 million people compared to 25,000 from the last calculator. Additionally, it's a little bit more recent data than the old calculator. So this calculator data comes from around the year 1992 to 2017, and the old calculator was prior to that. So more recent data, a lot more people. Hopefully this risk prediction will be a little bit more accurate. All right, and we're gonna go to a push in about 5 seconds. So kind of meet me there in 5, 4, 3, 2, and 1. All right, so more people, more recent data, hopefully better. The big changes also in this calculator are that it includes BMI, which we know BMI does increase, increased BMI does increase your risk of cardiovascular disease. The other thing that it includes is the GFR. So the other thing we know is that renal disease, renal dysfunction actually increases risk of cardiovascular disease as well. So taking those into account, I think, is good for this calculator. It also adds an optional A1C and albumin to creatinine ratio. So you don't have to use that, but if you have that data, you can plug it into the calculator as well. This new calculator doesn't use race anymore. Instead, it uses zip codes, and that kind of helps correct for social determinants of health. We know that patients who have socioeconomic issues often live in different zip codes, And so it takes those zip codes into account rather than race, which I think is going to be a better predictor as well. The other difference in this calculator is that it looks at ASCVD risk and also heart failure, both separately and together. And so the other calculator did not take into account heart failure. So this is a little bit more accurate in regards to that. This calculator also allows you to calculate the risk of patients that are a little bit younger. So you can calculate the risk of 30 to 40-year-olds as well as older folks. So the 10-year risk allows calculations for ages 30 to 79. And we're going to go to base in about 5 seconds. 4, 3, 2, 1. Decrease that speed or incline. So this calculator allows you to do a 10-year risk for 30 to 79-year-olds. It also allows you to calculate the 30-year rather than lifetime ASCVD risk for 30 to 50-year-olds. So a little different in that regard as well. This calculator does make it so that less people qualify for statin therapy, and that's probably appropriate. I'm very curious as to how it's going to work with my own patients, and I'm going to be kind of looking at the old ASCVD risk calculator and comparing it to the new calculator and see how that changes things. I'm looking at both. I've already done it with one patient, but I haven't done it with more than that to really see. The one patient I did it with was about the same, but I suspect if I take a look at enough patients with enough different risk factors that I'll see some big differences. So to start trying out the Prevent calculator, I'm going to put the link in the comments underneath my video if you want to take a look at that. All right, so we're still at base for another 45 seconds or so. The next topic we're going to talk about is the RSV vaccine recommendations. So that's a newer vaccine for older individuals. It initially was recommended 60 and over, and it was a risk-benefit discussion with the patient and the physician. It has now changed. The ACIP has reconvened and made some new recommendations, and now they say that those that are 75 and older would benefit most from the vaccine. So those are the people that should get the vaccine. And we're going to go to a push in 5 seconds. 3, 2, 1. So 75 and older should get the vaccine. Those are the patients that are really going to benefit the most or increased risk of complications from developing RSV. Those that are 60 to 74 should not get the vaccine if they don't have any risk factors for those complications. So if you're 60 to 74, pretty healthy otherwise, you shouldn't get the vaccine. However, if you have chronic lung disease or heart failure or immunocompromised or anything else that increases your risk of complications from getting RSV, you can consider getting it in that age range from 60 to 74 as well. The RSV vaccine has been shown to have a slight increased risk of Guillain-Barré syndrome in patients who have received it. So that's just something to take into account when you're counseling patients about this vaccine. And another reason why you really want it to benefit the patients as much as possible. And that's why really making it so 75 and older are the ones that are recommended to get is probably a good idea. So yay, that's a new thing in medicine. The third topic we're going to talk about is metabolic dysfunction-associated steatohepatitis, or MASH. That was the old, that's a new term for the old non-alcoholic steatohepatitis, or NASH. So it used to be NASH, now it is MASH. So that's the first thing I want to tell you is that there's new nomenclature. So start using that new term for it, so MASH. The other thing is that there has been a study that's been shown there's a medication that reduces fibrosis in patients that have MASH. Okay, and we're going to go to a base 5, 4, 3, 2, 1. Okay, decrease that speed, decrease that incline. So there's a new medicine called, and bear with me, I'm not the greatest with new drug names, but resmetirom. So resmetirom. It's a new medicine. They did a study that showed they took 960 people with fibrosis, so F1B, F2, or F3. They randomized people to placebo or one of 2 doses of this new medicine. And they showed that people that took the medicine had a 50%, or 50% of those people had either resolution or a significant reduction in the fibrosis that they had in their liver after taking it. So really has shown to decrease the fibrosis. The way that it works is resmetirom is a thyroid receptor hormone agonist, beta agonist. So there's a couple of different receptors. Okay, and then we should be pushing now. So 5, 4, 3, 2, 1. Let's push. So there's a couple different receptors for the thyroid hormone receptor. And one of them, called the beta, is actually more specific for the liver. And so they have done an agonist of that receptor that helps to clear the liver of fat, because it kind of is just in the liver. So this medicine kind of really focuses on fat accumulation in the liver through the thyroid hormone receptor beta agonist. So kind of a new exciting thing. There wasn't much to help treat MASH. Oh, I think I messed up just a little bit. That's okay though. That's okay. We are pushing. You should keep pushing with me. So there wasn't that much that could actually be treated for MASH. And so now we have this medicine. There's been a couple other studies that have shown that in patients without diabetes, that vitamin E probably helps. The other thing with patients with diabetes, pioglitazone has been shown to help. And then GLP-1s have some data to show that they help as well. The real tried and true therapy is weight loss. And so really counseling patients on weight loss is really what we should be doing first and foremost. If they're not able to do this weight loss, then we should be able to kind of offer them some other options. And resmetirom is one of those options. It is about $5,000 a month right now, and so it's probably cost prohibitive for a lot of our patients. Not sure how insurance is covering it. It may be that, it may be that insurance will cover it if certain hoops are done. So that's kind of where we are there. The other thing with resmetirom is that it does increase the risk of diarrhea and nausea compared to placebo, like many other medications. So. All right, in about 30 seconds, we are going to go down to a base. Go back to base in 30 seconds. So that's the third thing I wanted to talk to you about. So yay, we're getting there. Thank you for bearing with me. So excited for this. The fourth thing I wanted to talk to you guys about is actually HPV self-collection. Okay, we got 5, 4, 3, 2, 1. Base. Decrease that speed, decrease that incline. All right, so HPV self-collection. So this is actually screening for cervical cancer. We all know that cervical cancer screening is really effective in reducing the risk of cervical cancer. Many patients who have been diagnosed with cervical cancer have not been screened in the past or not been recently screened in the past. So if we can get more and more women or people with a cervix to be screened, then we're going to reduce the risk of cervical cancer and risk of death from that. There are barriers sometimes for patients getting cervical cancer screening. So in particular, women who have a history of sexual abuse or sexual trauma, the pelvic exam can be not only a physically traumatic sort of experience, it can also be an emotionally traumatic experience. And so reducing that level of trauma with a different mode of collection can be helpful for this population. So HPV self-collection has now been approved by the FDA. There are 2 kits that are approved. It's still supposed to be done in the office, but a woman can do it themselves. So the woman has a vaginal a swab, and they put it inside the vagina for a certain amount of time, follow the directions, and then send that sample off to the lab, get tested for HPV, and that has been shown to be a way of screening for cervical cancer. Still not the gold standard, but definitely an option for those women that may have had a traumatic experience, are fearful of a pelvic exam. Patients in gender minority groups as well may feel more comfortable with this method. And patients that don't have a lot of access to healthcare otherwise may also benefit from this. All right, we are gonna go to a push. 5, 4, 3, 2, 1. All right, so that's HPV self-collection. I'm always a fan of anytime we can provide different means of screening for cervical cancer. Everyone is different, and we need to meet patients where they are. So this is exciting development. All right, how are you guys doing? I am doing great. We are getting through this workout and the medical info. We are on topic 5. Woo-wee, in a push. Okay, so the 5th topic is post-exposure prophylaxis with doxycycline. So, sexually transmitted infections are on the rise. Syphilis, gonorrhea, chlamydia are all on the rise. And anything that we can do to help reduce the risk of developing this is welcome at this point. So there was a few studies that have shown in the groups of men who have sex with men and transgender women, those that are at increased risk for sexually transmitted infections, like had a history of STI in the last year, have other risk factors for STIs. It's been shown that if you give them the option of taking 200 milligrams of doxycycline within 72 hours after condomless sex, it reduces the risk of all those 3, so syphilis, gonorrhea, and chlamydia. There's been a rise in syphilis in many areas of the country, and so this, I think, is a welcome development. It's not been shown in those studies. It has not been shown to be helpful for cisgender women, so it's not being rolled out to that group at this point. So it's just MSM, and transgender women with increased risk of sexually transmitted infections.
Okay, base.
And this is not, you have to do it. It's one of those things that should be a risk-benefit discussion with patients that are in these groups. And the reason that is because, obviously, anytime we expose patients to antibiotics, there is a risk for resistance. There's also a risk for side effects such as C. diff, GI side effects in particular with doxycycline. So those do need to be taken into account. I am excited about this development. I think anything that we can do to help prevent sexually transmitted infections is kind of welcome. And there are a lot of new guidance for this group. So monkeypox vaccine guidelines have changed recently-ish. There's been a few other changes. So just something to kind of make sure to keep on top of for this population. All right. We have another 45 seconds or so, and then we're going to go to a push. And we'll also kind of start doing our last topic, which, yay, last topic. Hopefully I wasn't too awkward during this. All right. So our next topic is actually a new antibiotic that's been approved, or not a new antibiotic, but an antibiotic that's been newly approved to treat simple urinary tract infections in the United States. So it's actually been used in European countries for a long time for this purpose. And then we're going to go to a push in about 3, 2, 1. Okay, push. So the new medication is called pivmecillinam. Bear with me again. But it's a new beta lactamase. It's been shown to be helpful for treating just simple urinary tract infections. It actually is less likely to cause resistant isolate than many of the other antibiotics. It also covers ESBL organisms, and we don't have a lot of antibiotics that help prevent these, or help treat these. So that's a welcome kind of development as well. We are not supposed to be using these in pyelo because it's kind of like nitrofurantoin. It doesn't really penetrate the kidney. So if you're thinking this might be early pyelonephritis, shouldn't be using it. We're gonna go down to base for a minute, and then we're gonna finish out the walk this last minute. We're just about done. Can you believe it? We're almost, that went so fast. Okay. You have no idea how many times I did this to get this one. So thank y'all for bearing with me. So yeah, a new antibiotic kind of reached for. I was not able to find how much it cost, and so that would be my main concern. I wasn't able to find out how much it cost quite yet. Hoping that it's reasonably priced. It is not first line for simple UTIs. That is still, nitrofurantoin. And fosfomycin is second line along with this new medication. So exciting times for primary care physicians, lots of new things. So we are done now. Thank you guys so much. We made our 20-minute workout. Thank you for sharing in this with me. Please let me know if there's anything we can add, include, change. Happy to take feedback. And thank you for letting me share my two loves with you. Have a great rest of the day. Thank you. Bye. Go stretch. Make sure you stretch. Okay, bye.